If everybody can have a seat. So just to make sure we're all in the same place, the conference today is called Cognitive Disorders, The Journey on the Road to Informed Practice Through Interprofessional Research and Evaluation. I'm Dr. Gambert. I'm the Division Director for Geriatric Medicine at the medical school. And Dr. Jay Magazina asked that I just say a couple of opening words because he could not be here today. He sends his regrets. He had a family issue he had to deal with. So on behalf of Dr. Magazina, who could not be here today, I would like to thank our co-sponsors for the event. There's a whole bunch of them here. The University of Maryland Center for Research on Aging at the School of Medicine, the Claude D. Pepper Older Americans Independence Center, the VA Geriatric Research Education and Clinical Center, the Peter Lamé Center on Drug Therapy and Aging at the University of Maryland School of Pharmacy, Geriatrics and Gerontology Education and Research Program at the University of Maryland Graduate School, the Biology and Behavior Across the Lifespan Organized Research Center at the University of Maryland School of Nursing, and lastly, the Mid-Atlantic Nutrition Obesity Research Center at the University of Maryland School of Medicine. Dr. Magazina would also like to thank the Planning Committee, which includes myself, Dr. Blumenthal, Reba Kornman, who also sent her regrets she could not be here today, Bernadette Seaton, Nikki Brandt, Amanda Lering, and Ann Sullen. So thank you to all of those individuals. So before we begin, just a few housekeeping. Please silence all of your phones if you've not already done so. Please sign in using the sheets here. And we hear that there will be some refreshments later, just to tell you for those interested in that. And today's event will be moderated by Dr. Bernadette Seaton. She's an assistant professor in the Department of Medicine, is one of our premier clinician educators. She's also the associate program director of the Rheumatology Fellowship Program. So, Dr. Seaton, welcome. Thank you for coming.
Thank you, Dr. Gambert. Welcome all. Thank you for choosing to stay here for some wonderful talks instead of sunning yourselves outside. Stay for the cookies. I hear they're great. So I am pleased to introduce the first speaker, Dr. Jacob Blumenthal, who is an assistant professor in the School of Medicine, Division of Gerontology and Geriatric Services. He is a clinically trained geriatrician and clinical investigator focused on improving the function and quality of older adults with chronic conditions. Dr. Blumenthal has a particular interest in the burdens of medications on older adults with multiple comorbidities. He's also deeply involved in education. He serves as a co-director of the University of Maryland Geriatric Medicine Fellowship, or he's now the director as of a few days ago, taking over for the esteemed Dr. Conrad May, and he's acting associate director of education and evaluation of the Baltimore GRAC. I'm pleased to introduce him, and his talk is entitled Strategies to Promote Independence and Mitigate Functional Decline in Those with Cognitive Difficulties.
Stop. Thank you. I'll do my best. Thank you for that very kind introduction and for the invitation to speak. I, as a rule, am a relatively informal speaker, so if you have questions, please feel free to raise your hand or shout them out, and I'm happy to entertain them. We're going to try to do this a little bit loosey-goosey. So what we're going to talk about today are strategies to promote independence and mitigate the functional decline that we see also too often in those with cognitive difficulties. And first, I'll, in just a full disclosure, tell you that I have no disclosures. I do not work for a drug company. I do not own stocks or bonds on anything that we're going to be discussing today. To give a quick overview of what we're going to talk about, we're going to start just reviewing just the facts, if you'll forgive the dragnet analogy. We'll talk a little about the demographics, the aging of the population. We'll talk about the implications of the aging population, the increased prevalence of dementia, and where we've been and where we're going. Then we'll talk about some of the challenges that these patients present, some approaches that have been tried to deal with these challenges, and sort of what do we know and what don't we know, and hopefully find some future directions. So my objectives are relatively straightforward. At the end of this presentation, you're going to be able to describe the extent of functional decline, dependence in dementia. You'll be able to review some of the approaches to these problems and identify, hopefully, some potential avenues for future research. So first, the facts. As you know, we are facing a tsunami of older individuals, and the prevalence of dementia increases dramatically with age. Currently, there are about 6.8 million Americans that have dementia. About 5 million of these have Alzheimer's disease. And by 2050, so in a brief couple of years, the number of Americans living with Alzheimer's could rise to 16 million individuals, which is a staggering number. 1 in 3 seniors has dementia. And as I mentioned, these numbers are increasing. I should, in fairness, mention that these temporal trends in dementia are somewhat tempered when you look at dementia as a whole. So Alzheimer's, the numbers are increasing logarithmic, really. Look at dementia as a whole, those numbers are sort of leveling off, and that's because things like vascular health, traumatic brain injury also contribute to dementia, and as we've gotten better at controlling cardiovascular disease risk factors, as we've gotten better restraints in cars, the burden of these conditions is decreasing. That being said, this is still a gargantuan problem. And I open up with, as I want to do, with poetry. Thomas Gray, I don't know if many of you remember Elegy Written in a Country Churchyard. The boast of heraldry, the pomp of power, all that beauty, all that wealth e'er gave, await alike the inevitable hour. The paths of glory lead but to the grave. So there's no getting around getting older. There's no getting around the conditions that accompany aging. And if medieval poetry wasn't enough, I'll refer you back to thermodynamics and the second law. Entropy increases, and so as things go, things break down. So in particular, dementia, this is a chronic acquired decline in memory in at least one other cognitive domain of sufficient severity to affect daily life, and it can affect any number of cognitive domains. Frequently we see problems with memory, we see problems with language and attention. Dr. Gamber and I were just speaking about visual, spatial, and processing difficulties that are becoming increasingly prevalent as the burden of traumatic brain injury is increased and other conditions. And a relatively global phenomenon that is particularly striking in many things, including Alzheimer's, is difficulties with executive functioning and planning. This is also seen in frontotemporal dementia. So dementia is prevalent and it's increasing. As I mentioned, the incidence increases with age. And so this is some data from this is the CDC that just looks at the incidence of dementia by age. And again, this is incidence, so these are new cases of dementia. And what you can see here is that as you go up in age, the chance of developing dementia increases quite dramatically. Furthermore, given the demographic trends that we talked about, this is prevalence data, looking at the number of individuals with dementia by age. And here, the blue line is the total number of people in the United States with dementia. And in orange, gray, and yellow at the bottom are broken down in increasing ages. And what's lost here in scale is shown on the next slide. And so what you can see here is that the prevalence of dementia is increasing dramatically and quite strikingly in those over the age of 85. If you look at the younger group, 75 to 84, the increase is even greater. And if you look at the youngest group, the baby boomers, this group is increasing quite dramatically. And again, this is not pathophysiology, rather this is demographic trends. This is the baby boom, and this is where we're headed. So this looks at the projected prevalence of Alzheimer's disease, and again, it's the same sort of data. And what you can see here is that there are millions of Americans that are currently afflicted with dementia, with Alzheimer's disease, and that these numbers are going to increase quite dramatically. So the first challenge that these individuals present is behavioral challenges. So dementia affects multiple domains, not just memory, not just language, but also things like orientation, insight, personality can be quite dramatically affected, and the end result is difficulties with self-care and higher level functioning. But not only these problems with pure cognition, there are also behavioral and psychological symptoms that occur all too frequently. There are problems with perception. There are difficulties. So patients with dementia may have hallucinations or misappreciations of their environment. There are disorders of mood as well as thought content. And perhaps most troubling, there are inappropriate behaviors. And it's these behavioral symptoms of dementia that account for the vast majority of nursing home placements. So as I mentioned, neurocognitive problems are very common. This is from a variety of studies, and what I want to impress upon you is just how frequently these problems occur. So we see agitation or aggression in about a quarter of patients with dementia. Hallucinations or delusions you see in just under half of them, and more than 75% of patients with dementia will report non-psychotic agitation. And so these are things like restlessness, wandering, having intrusive thoughts or repetitive behaviors, irritability, some sleep disturbances. A common occurrence that we see is what's so-called sundowning, as well as the psychotic symptoms that I mentioned here. The impact of and these occur to varying degrees with varying types of dementia. So certain types of dementia are associated more with psychotic symptoms than with agitation symptoms. But looking at Alzheimer's, which accounts for the vast majority of dementia, there is a sequence of symptoms such that early on there is more depression and withdrawal. As the diagnosis is made, people's mood is noted to be different. There's increased irritability, agitation, and then as the disease progresses, we see more hallucinations, more aggression, and the like. So the impact of these behavioral symptoms is quite severe. They are the primary drivers of nursing home placement. This is how people get from living independently or with their families to an assisted living facility or a nursing home. The behavioral issues are what drives this. It also drives healthcare utilization. People that have behavioral issues more frequently are referred to the emergency department. They're more frequently admitted to the hospital. And when this happens, the healthcare utilization takes off. And finally, this is a great burden on caregivers and their families. So the end result of these is that there is a tremendous need for ways to deal with these symptoms. And a variety of approaches have been tried, and they can be broken down into four main categories. Infrastructural and individualized approaches, approaches focusing on communication, approaches focusing on behavioral management, and approaches focusing on rehabilitation, again, paying attention to the functional decline that is seen in dementia. And in particular, these behavioral issues, What has been most successful have been multi-component interventions. The evidence suggests that caregivers may benefit from increased support in the family. There is some evidence suggests that even remote interventions can be helpful, and this is particularly important because not everyone can live in an assisted living, or not everyone can have the supports that they need in their home. So what we've tried to do is move to things that are more distantly provided. However, the results of these interventions, and we don't have time to go through all of them, but there have been probably dozens of interventions looking at various trials of supports that you can provide from a distance. And generally, these results are inconsistent. Some studies have shown some benefits to having someone that the patient can call, providing caregiver education, providing environmental cues. But largely, these have been small trials, and they've not had standardized approaches or standardized measures, so it's very difficult to ramp them up. One of the things that we do see quite clearly is that people with dementia have tremendous unmet needs. And so this is data from across town looking at unmet needs of patients with dementia. And what you can see is that being concerned about safety as well as support for the caregiver occurs almost universally. There's a great need for caregiver education as well as meaningful activities for the patient to participate in. Problems with functioning actually occurs relatively infrequently. Just under half of the patients that in this series reported difficulties with that. And so the approach has been, what can we do if the problem is not ADLs? What else can we do to keep the patients in their home? And so this is work that was done at Hopkins, looking in their memory care unit, and they developed a community and home-based intervention, and they looked at dyads, at individuals and their caregivers, and looked at quality of life. And what they saw was that the quality of life for the patients was higher than for the caregivers, and that the quality of life was inversely related to the number of medical conditions, again, not surprisingly. So things are hard for patients with dementia and their caregivers. They're harder for the caregivers than they are for the patients with dementia. And the difficulty is inversely related to the number of health conditions, suggesting that we need to find a way to meet these unmet needs. So as I mentioned, there have been a number of approaches to support the caregivers, peer support, family support. We've tried things like support groups and internet connections for patients with dementia. And as I mentioned before, there are sort of insufficient evidence to recommend any one of these. What we come back to is that behavioral issues are the determining factor for long-term care. Increased caregiver burden, worse caregiver health, and caregiver psychosocial factors are the predictors of who ends up in a nursing home. And these are poorly addressed pharmacologically. So Nikki's going to talk about the meds, and what I can tell you is that there are very few good meds. The meds that do much have side effects that are quite daunting. And so meds are not the answer. Rather, what I believe, and what I think is the developing sense of those of us who do this work here, at least, is that optimal clinical care involves individualized management of individualized patients and their caregivers, personalized treatment, personalized pharmacotherapy when it's necessary, and ideally much more non-pharmacologic treatment. This is, again, some work that was done, recently published in JAGS, looking at a standardized approach to patients with dementia. It was a team-based approach, and what they found was that by supporting the caregivers and providing ongoing care in a specialized setting, they were able to, although not changing the overall trajectory of the disease, significantly reduce caregiver stress. The other problem that we see, so behaviors are a huge challenge. The other challenge that we face is function. And so this is looking at, on the y-axis is Barthel activities of daily living. So this is function on the x-axis, and on the y-axis is MMSE, mini mental state exam scores. And what you can see here is that there is a quite, in the Barthel index, the higher the number, the more impaired you are. Just to be clear that that's why this is in a positive direction. So that the, no, I have that backwards. The better Barthel index is the higher number is better function. And what you can see is there's a linear relationship between cognitive status on the y-axis and functional status on the x-axis. So how do we address these functional difficulties in patients with dementia? And we've tried a variety of interventions. This is a particularly good intervention. This was recently published in the Annals. And this is out of Ohio, and this looked at a collaborative care model with the addition of occupational therapy. And so the collaborative care was patients and their caregivers came in, a complete comprehensive plan of care was developed with their involvement, and patients were randomized to either bi-monthly in-home occupational therapy or a control. And they were, this was done in three parts. The first time was every other week, then they spaced out the visits to once a month, and then they spaced out the visits to 1.5 months. And at each of these cycles, they reassessed the patient. They looked at their functional status. They looked at neuropsychiatric symptoms. They looked at quality of life. And so this is best care. Okay, so collaborative care with a team-based approach, and now we've added on top of that occupational therapy. And what you can see is a whole lot of nothing. So if you look at ADL function, if you looked at the intervention, there is, again, a decline in functional status as the disease progresses. This is not attenuated by the intervention. These are not significantly different. Similarly, if you look at PHQ-9 or NPI scores, there is a decrement over time, and this is not attenuated by even this best of all possible interventions. There's a hint that perhaps there's an improvement in PHQ-9 at 12 months, but not a whole lot. So kind of depressing. Some things that have also been tried in the nursing home have been ongoing training of patients as well as environmental redesign. So redesigning the units to make them more dementia-friendly. Things like ambient music, multisensory interventions like a Snolzen room. And these have been sort of a very, very mixed bag. And I think this points out the need for further interventions because these have all been relatively small studies. They've been not standardized in any meaningful sense of the word. And so that what works in one group and doesn't work in another group leaves one wanting. These make sense from a common sense standpoint, but we simply don't have the data to support them. So what has been shown to be nursing home factors that can decrease the likelihood of behavioral disturbances are things that make it much more like a home, make it less institutionalized. And so there is some intriguing data suggesting that structured activities or even social activities can decrease behavioral disturbances. But again, these have not been studied in a large manner. A subject near and dear to my heart is exercise in the nursing home, and this is, again, a recent study looking at, it's a randomized controlled trial, people with severe Alzheimer's disease. These had an MSE of 11 at baseline, very poor functional status. And again, what you see is that their functional status declines over time, and it declines the same whether you get an exercise intervention or social control. Their mini mental status score decreases over time, as does their gait speed, and it's not different. One of the things that is, how many, 5 minutes am I, or am I over already? Less? Okay, so we'll get over these. So one of the things that I think is very interesting and intriguing is information and communication technology. There are mostly uncontrolled studies, but I think this has the potential of really addressing this disconnect between where the patients are, what their needs are, and where the providers are. And so we're currently developing a study in the Baltimore VA looking at a robot as a companion that might help to increase communication. So in summary, functional decline and decreasing independence, increasing dependence is all too common in dementia. Behavioral issues in particular are particularly frustrating and require an approach that is universal. I think there is some promise despite these depressing statistics. I would again invoke Mark Twain. Never let the data get in the way of a good story. And so I would ask you to indulge me and accompany me as we continue onward. And I thank you, and I apologize for running over. Are we doing questions now, or are we questions later? It's up to you. You're the moderator. Okay.
Thank you, Dr. Blumenthal. I am pleased to introduce our next speaker, Dr. Nicole Brandt. Dr. Brandt is a professor of pharmacy practice and science and executive director of the Peter Lammy Center on Drug Therapy and Aging. Since joining the University of Maryland School of Pharmacy, she's expanded the range of geriatric training opportunities, including its geriatrics pathway and ASHP accredited geriatrics residency. She's a keen interest in interdisciplinary and interprofessional education and has promoted programs both within and beyond the campus. Dr. Brandt has been active in promoting optimal care for older adults and has affected this through her educational, clinical, as well as healthcare policy work. She is here to talk today about medication safety concerns among older adults with cognitive disorders. Please help me and welcome her speaking.
Thank you. All right. Well, first and most, thank you for staying. I know it's beautiful outside, and we should be getting our vitamin D, which has questionable benefit in terms of cognitive health. We could get into that. And I thank you, Dr. Blumenthal, for giving kind of the prelude. I'd love to say I'm up here talking about the next breakthrough in medications for Alzheimer's disease, but sorry, we don't have anything. So I'm going to take the flip side and talk about medication safety. So as the pharmacist on this team, I just want to give you a bit of a background because we don't have any great medications. So I do have some disclosures. I love to be completely transparent. So I don't speak for pharma. I don't work for pharma. But I do take research monies from some national organizations. We're doing work with HRSA, with promoting geriatrics care amongst primary care, and I'll speak to some of the work we've done. We're currently doing work with Managed Care Pharmacy Foundation, looking at beneficiaries and caregivers' perspective on medication therapy management services, which I, again, will speak to today a little bit. And we're currently doing work with Impact, which is a CRO organization here in Baltimore, doing work on, again, program design in terms of looking at medication safety. So all of those in some ways may impact what I'm sharing with you because I love policy stuff. I also serve as a consultant with RAND. We did work on medication reconciliation, Institute for Healthcare Improvement with doing some work on age-friendly health systems. And AGS, I am an author of the Beers criteria and have worked on the multimorbidity stuff. And then in my recent spare time, which I have so much of, I am working with NCQA on GMAP, the Geriatric Medicare Advisory Panel. I really think it's important to have a pharmacist's voice at the table when it comes to medication use and safety. So I still practice, and I have worked with Drs. May and Dr. Blumenthal through the years. And I know that Dr. Blumenthal isn't as self-promoting as I am for him, so I'm going to actually share some of his work within my presentation, as well as Dr. May's and Dr. Lorick. But at the end of this program, I think it's important for all of you guys to be aware that medication use and safety amongst older adults and those with cognitive impairment is a really big concern. Unfortunately, we don't have a cure. We don't even have a disease-modifying agent. We just have symptomatic management. So what I find patients typically doing, and we'll allude to this within the talk, is they start self-treating. And they use all kinds of different medications to do that. So I want to give you some imparting wisdom of what you can do in your practice to try to tackle this. And as been alluded to already, engaging the caregiver and healthcare team who's struggling for health information and support them. So I'll share some tools that we've actually developed here at Maryland. So without getting political, but our former president, Barack Obama, stated it well, and we know that throughout each of the states in the union, they have an Alzheimer's plan, and varying degrees of how they're tackling that. I think, and I won't ask because it's a private matter, but I'm sure all of us on a personal and definitely on a professional level, if you're doing geriatrics, are caring for older adults that are dealing with dementia. And we are struggling with that. There has been allocation, and if you look at and you follow the grant dollars, like many of us in this room, there's been increasingly allocation for both benchtop research, practice research to help our older adults truly age in place. Because what I definitely have seen is this decrease in nursing home beds. And so we're trying to keep people out of institutional settings, but we're not really giving them the support structure they need to stay in the community. So even if those studies don't always show the robust results, it's amazing how comforted caregivers are by having somebody to talk to. So this is what we're left with. Too many Americans feeling like they have a love affair with prescription medications. We'll talk a little bit about some of the, what I like to term medication stewardship initiatives that are going on that are really important. And from this same consumer survey report, 2/3 of the patients who were surveyed said they never had a healthcare professional do a medication review with them. They didn't break down the demographics, but I think it speaks to us in terms of, are we doing an adequate job, or at least do our patients perceive we're doing an adequate job with reviewing their medications? So I think there's more work to be done. So that's why we are here. So this was an interesting case. This gentleman came in with his suitcase, and he was coming in. He was referred by primary care because he was, they were suspecting he wasn't making good choices. He was emptying his bank account, and he was purchasing, as you can see in this suitcase, quite a few nutraceuticals, and he had at his disposal many high-risk medications, we would say. He had a bottle of diphenhydramine, he had a bottle of oxycodone, he had a bottle of oxybutyrate. So for those of you who are not pharmacists, everybody knows oxycodone because you hear about it every 30 seconds in the news. But for those of you who don't know diphenhydramine, it's Benadryl, which is particularly problematic because of anticholinergic. And then oxybutyrate is an agent to help when you have overactive bladder. And all of those medications are potentially problematic in older adults with cognitive disorders because they block the existing neurotransmitter acetylcholine to have an effect on whatever receptors we may have left. So this is not uncommon when we look at the literature, whether you're in the community, then you go to an assisted living and you go on to a nursing home for higher level of care if needs be. You'll see this incremental increase in number of medications. But I think what's concerning is, unlike assisted living and nursing homes where we can control access, we can't control access in the community. And some of our patients are oftentimes self-medicating. So the family, this gentleman's family, his one son was a physician. They had a nurse, but they said, we can't control Dad. That's why we need him here for an evaluation because we're concerned about safety. And of course, he was concerned about driving. He thinks he can drive. So, so I won't say what his MOCA score was, but it was definitely not in the normal range. So with that, we know that policy, so with polypharmacy, excuse me, we know out of the work of Terry Freed, it's a nice systematic review published in JAGS, those of you guys familiar with JAGS, the Journal of Geriatrics with AGS, published this great review. And it's no surprise. We've seen this over and over in the literature. As we increase the number of medications, we increase the risk for adverse drug events. Now, the key thing is when you really dig into the clinical trials within the systematic review, you'll find that there's a difference in how we define polypharmacy. Some define it as 9 or more medications. Some define it as 5 or more medications. I personally, as a clinician, like to define it as more medications that are clinically warranted. because especially when we're working with patients with cognitive disorders, the more medications we add, the more likely they're not going to take them well. And it's a burden on the caregiver too, especially when they start to manifest neuropsychiatric symptoms and they become paranoid about those medications you're taking. As we increase the number of medications, we increase the risk for falls. We're currently in the 2018 revision of the Beers criteria. Does everybody know what the Beers criteria are? I gave my disclosure, good. So as long as everybody knows what it is, as we're in the current revision of the 2018 Beers criteria, we're looking at falls and falls and falls and falls and falls in terms of lots of different medication classes. And people look at falls and fractures oftentimes in terms of combination. But again, as we increase the drugs, we increase the risk of falls. And especially with agents like our benzodiazepines, which are potentially problematic in older adults, our SSRIs, we've seen literature out there with that. But now we're starting to see this emergent with other antidepressants, which is a conundrum when we think about neuropsychiatric symptoms in dementia patients. We often go to those medications to avoid antipsychotics and to avoid benzodiazepines, but what are we left with in our armamentarium? So again, polypharmacy is one aspect, but the individual aspect of it is a problem themselves. And then, of course, as we increase medications, and some of the work we did, I won't go into it, but when we did a sub-analysis looking at psychopharmacological medications in nursing home residents, we saw an increased signal for mortality looking at that psychopharm burden. And so there's a lot of attention being given to antipsychotics and other CNS active medications. So again, increase in number of medications, increase in certain types of medications, increase the risk of negative outcomes. And so we see this being a very big target of how do we put our arms around healthcare cost. So there's a lot of attention being given to non-adherence of medications, and we're seeing $290 billion in healthcare costs annually. And it's estimated that half of chronic disease medications are not being taken as prescribed. So I see programs out there that try to remind people from telephone reminders to automatic refill patterns. But medication non-adherence, especially in those with cognitive impairment, are quite a big issue. And it's costing us, as patients are not taking their meds well, or maybe taking them inconsistently, or taking too many of them, that we're spending even more money on adverse drug events. So when we hone down in terms of the work that's being done out there, we try to devise where do we strategize with interventions. So, and when we look at some of the highest risk medications with some of the implications of readmission or emergency department visits, anticoagulants, I think we're all familiar with things like warfarin or Coumadin, but the novel oral anticoagulants are problematic. Antibiotics in terms of their safety and concern. Diabetes medications, especially our insulin preparations, and our opiate analgesics are some of the most common drug classes. So that was Butinit's work that came out originally in 2011, was updated in 2014, and continues to kind of be a concern for us. So what do we do within our systems to try to address that? Further complicated by then you've got this older adult with dementia, or older persons with dementia, PWD. Gotta love more acronyms. But what we see from some of the studies out there, again, is medication management is suboptimal. It's kind of intuitive, right? There's errors in prescribing, because oftentimes we're giving multiple psychoactive medications to a very vulnerable brain, and they experience delirium a little bit easier. We're seeing definitely that signal out there. But then the errors in administration, because they may be combative or they may be confused and self-medicating. And so this is significantly leading to community hospital and residential care costs. There have been estimates out there from different work that there may be a 5 times greater cost expenditure if a person has comorbid dementia than other populations when you match for other risk factors. So we're seeing a disproportionate amount of money being spent, which makes it challenging. But what we know is there's a lack of ongoing systematic approach to really looking at high quality medication communication process during care transitions for dementia. And I think this is an important moment to pause. How many of you work within a health system? A couple of hands going up. How many of you screen patients for delirium and dementia before they leave the door of that health system? Maybe? Okay, good. And then how do we put things in place to ensure when they're going home that they're still able to self-medicate? if they're self-medicating. So just things to think about, because what we're finding is there's more work going on in terms of looking at upon discharge or upon transition of care. How are we handing off? How are we screening for maybe some cognitive impairment, executive dysfunction that may have been a sequelae of an event, or maybe just even the hospital, a new onset delirium. So I think it's important because oftentimes what we're depending on is an educated patient, an informed caregiver, but that may not be happening during those care transitions. So some colleagues of ours actually did some work up in Pennsylvania, in Pittsburgh, and they looked at supporting older persons with dementia during these care transitions. And they saw, again, the importance to look at engaging caregivers, support team members, and their ability to self-medicate. So without sounding too promotional, we'll talk a little bit about the MedMaid, which is the medication management instrument for deficiencies in the elderly. I don't think Dr. Orwig's here today, but Dr. Orwig and I worked together on this tool. It's a paper tool which looks at identifying knowledge, ability to administer medications, and their access to medications. And our colleagues in Pittsburgh actually used this with caregivers and persons with memory loss, and saw that it helped to engage them in a systematic, structured approach. So I know we're continuing to look at this work, and we're actually just submitted a grant to the state looking at discharge from the nursing home back home. We do a lot of focus on the hospital back home, but not so much from the nursing home to home. So we're actually using this tool. So if those of you guys are interested in this arena, please talk to either Dr. Orwig or myself. And then I want to promote the work that was done recently at the VA, Dr. Blumenthal and Dr. May. I think it's really important. There was a demonstration project, Dementia Evaluation and Management Outreach, and I'm going to give you my perspective as a pharmacist on this amazing team. So this particular project really originated out of the core of the team focusing on interprofessional care. So basically, older adults would be referred by primary care to come in for the interprofessional team workup. We'd have neuropsychology, we'd have medicine, nursing, pharmacy, social work, really give their own assessment, put together a unified care plan, and then share that with the other team. What was interesting about demo, though, is we tried to reach out to the CBOCs, the community-based outpatient centers, and support them. We did some telephonic type work. We did some case management from afar, and really did this over a couple of years. I didn't share the economic data, but it was pretty cost neutral, and it was published in one of the federal journals. But I will share the pharmacist perspective here. When we went back and looked at the data, we did see an overall decrease in anticholinergic medications. We saw an improvement of medications to control vascular risk factors. We saw a decrease because we did a lot more debridement, I think, of psychopharm medications because we had Dr. Laura, who's a geropsychiatrist. And then we worked with the family members to help improve adherence, use pill boxes if they could be utilized, and looking at the number of meds, but also the frequency of meds. So looking at that pill burden and treatment burden. So those were some of our results that we actually, again, published and shared with others. And we presented it actually at IEGG in addition to some of the other work. As I mentioned, I'm a co-investigator with our campus here with Hopkins and their GWEP online, and something for those of you in your training program. We actually, our team, again at the VA, put together an online dementia training, giving an idea of what the different team members have done. So over the past 2 years, when I presented this data, we had approximately about 150 students who have completed it, 125 pre and post survey. And qualitatively, what we saw is increased recognition of the interprofessional team, speaks to the strength of the campus, the importance of team meetings, and the impact on patient care. So again, this is something online that you could use if you're working with students or maybe in your own personal training. So coming back to medications, working back from that article, so you can see that medications, the use of them is quite common and potentially problematic, and especially when we look and we break down polypharmacy, especially in older adults with multiple chronic conditions, we know that the feasibility of managing all of these medicines is not possible because of medication regimen complexity. We also know when you dig into looking at medications, especially from a safety perspective, oftentimes there's no indication. So a lot of work that's bore out of here are things like proton pump inhibitors during transitions of care. So patients may be continued on them upon leaving the hospital, which is problematic. The other thing is when we look at more than minimal risk of harm, excessively tight disease control. So over the last, again, I've been very impressed to see guidelines looking at patients in end of life, or maybe their last 12 months, and have a poor prognosis, really liberalizing how we tightly control diabetes, or how we have the data to support stopping a statin and showing no negative outcomes in terms of maybe cardiovascular outcomes or death. So I think when we look at where patients are in the spectrum of care, it's important to figure out not only their goals, but you as a clinician figuring out kind of how tightly do we need to control these medications to reduce polypharmacy, and of course then to look at medications that might be worsening their comorbidities. And so I think especially when we talk about dementia care, oftentimes family members are coming to you and asking, how tightly should I treat them? What should I be fighting with my loved one about when I'm giving medications? How do I improve their function? And I think it's important for us as providers to say what matters most to you. So I know Dr. Gruber-Baldini is going to talk about falls, but one of the things I hear from families is, how can I stop medications that might be making my loved one more rigid, or maybe making them feel a little bit more dizzy? So again, it's very individualized. There's no cookbook recipe to figure out what's the best approach, but the most tactful approach is what's important to that patient, what's important to that family, and reprioritizing goals of care. And oftentimes what I find is we have so many specialists involved that we're kind of weeding through what's the competing priority, and maybe preventative approaches aren't as important anymore, and really reducing caregiver burden is reducing number of doctor visits, not alone the number of medications. So I think there's a lot to consider, and I put this in the construct again of multiple chronic conditions. So if you are familiar with this work, I highly recommend, again, the American Geriatric Society put together a tool looking at multiple comorbidities and giving us kind of a guiding principle document of how to manage that. And one of the areas I helped work on was treatment burden, and oftentimes it's not just the medications, but the monitoring, the visits, the follow-up, and thinking about all the construct of what the burden is for the patient. So our team at the University of Maryland School of Pharmacy, as well as within the Lamy Center, we have multiple pharmacists there, and throughout our different work, we're looking at transitions of care services, and as I mentioned, there's a lot of attention being given towards medication reconciliation. Medication therapy management service is a Part D covered benefit for patients who either expend a lot of healthcare dollars, take a lot of medications, and it's a free benefit, oftentimes underutilized because it's hard to navigate. But as I mentioned at the beginning, there's a change in policy with the enhanced MTM, which is changing the eligibility criteria. So caregivers, and we've done a lot of education here to caregivers and SHIP workers, which are basically state health insurance program workers in the community, to say, hey, did they sit down with their healthcare provider? What I said at the beginning, oftentimes they're not getting those med reviews, and go through all of their medications to look for polypharmacy, look for high-risk medications. There are chronic care management telephonic services out there. I find that they can be very confusing sometimes to our caregivers and our patients, but it's something to look at. The other thing when we look about opportunities, because adherence and access is an issue, special packaging for this population may be important. But I think with any intervention, as you saw with the occupational therapy, the data was not that stellar. Sometimes the special packaging doesn't work because they get confused. And I say special packaging, those pill boxes I mentioned, or they could be individual pillowcases. There's lots of things out there. And I have to say, when I've talked to our tech people, there's a lot of people focusing on keeping older adults aging in place, improving medication adherence. So I've been impressed by the number of bells, whistles, sensors, alarms that can be embedded in someone's home to see if they're actually taking their medications from the vial to the actual pill. And there's a lot of debate on how useful those are and how invasive they might be. So I know we're using the world of safety, but I think medication adherence monitoring is on its infancy with technology, and we're trying very sometimes aggressive things personally, especially the pill with a sensor if you've taken it or not. So, but I think what's important is as we continue, I'm no longer with the VA team, I'm over with the MedStar team, and we're continuing to further programs to help patients age in place in the community. So more risk stratification, and that seems to be the way of the land in terms of looking at risk stratification and tools to improve care planning and interventions. I also want to spend a moment as we talk about patients and persons with cognitive disorders, some of the things we need to be aware of, because as we look at a population that is at greater risk, there's lots of medications we talked about that have higher risk. There's a lot of work going on in the realm of medication safety in a global perspective as well as a national perspective. So the one probably most noteworthy to this group is the antipsychotic and other psychoactive medications. How many of you are familiar with the 2012 initiative put out by the Centers for Medicare and Medicaid Services to reduce the inappropriate use of antipsychotics? Okay, great, hands going up. It's been a really interesting thing to look at. It's been kind of a top-down, bottom-up type of approach in terms of stakeholder engagement. And what we've seen by imparting clinical as well as regulatory mandates to reduce the overall use, first it was 15% up to 20% and almost nearly to 30%, we've been able to reduce antipsychotic use, but have we then put our loved ones, our elders at greater risk with other psychopharmacological medications? So there was a recent publication in Health Affairs with Judy Lucas looking at, well, we're starting to see a trend in maybe some of those other drugs being used. And that's the conundrum. There's lots of data out there showing the danger of antipsychotics. It's not FDA indicated, and unfortunately, we're struggling though with how do we manage neuropsychiatric symptoms when we oftentimes have a very low staff to resident ratio in some of our post-acute long-term care settings, and we have a rapid turnover, about 30% loss annually. So there's a lot more to be done in terms of helping our older adults age in place, not with medications. And so I want to spend a moment on something I think that's starting to get medical and health systems traction is this construct of deprescribing. How many of you guys have heard about that? Okay, some hands going up in the room. Well, I'll get there in a minute. So let me go into one of the other expectations because I want to talk about caregivers and consumers is engaging patients and families. Patients and families may place unrealistic expectation on the current roles of medication. So there's a neat little article in Gerontological Nursing saying that oftentimes they don't really understand and they think they're a cure and they're going to stop the progression and it's going to happen right away. Or I can take my PRN Aricept when I'm feeling a little bit more confused one day. These aren't how medications work, and I think we still need to do more education to both our patients as well as our caregivers, and that's what this particular survey showed. And again, talked a little bit about the MedMaid and the different domains and it being utilized out there. So let's talk a little bit about deprescribing. So deprescribing, and there's been other cultures and other countries that have been really adopting it. And I think when we think about our payer system here in the U.S., what I loved about the VA was a single payer model when it came to medications and medical care. So oftentimes I felt like I really knew what our patients were taking, except for what they might have been getting at the $4 Walmart or over the counter. But when we work out in the community, when we're in these fragmented systems and they use multiple pharmacies and mail order and they use multiple over-the-counter agents, it's really daunting. But deprescribing is really looking at the individual level, but then looking at the system provider level and making sure that we take a complete patient history. We look at inappropriate medications, determine what can be stopped and prioritized. And then from a systematic perspective, initiate medication withdrawal and monitoring. And I think this is really important. So I know that we're doing some collaborative work. Emily Reeve here is from Australia and working with Cynthia Boyd over at Hopkins with Ariel Green. So we're calling it Optimize, which is going to be deprescribing high-risk medications in Alzheimer's and dementia patients. So it'll be interesting to see, because what I definitely have seen is not only is it engaging the provider system, but it's also engaging the patient and the caregiver. So we're doing some work in our own clinic on deprescribing proton pump inhibitors. And one of the tools that can be used from a research and clinical perspective is getting their index of how willing they are to deprescribe, and then getting the healthcare providers willingness to deprescribe, because oftentimes there's barriers to wanting to deprescribe medications. And then if we do stop it, making sure that we actually stop it. And so I've seen quite a few misadventures when we think we stop the medication, but the pharmacy continues to give it because they don't know the medicine's been stopped. So I think deprescribing is really getting some traction in terms of, again, looking at medication use and safety over time. And our Canadians to the north actually have a wonderful website if you haven't seen it. It's called deprescribing.org. And this is just one of the examples of the clinical programs, or protocols rather, that go through the guidelines of deprescribing benzodiazepine and Z drugs, which are potentially problematic in older adults with cognitive disorders. Why I chose this one out of all of them, they actually paired this up with an Empower study, which actually embedded community pharmacists working with healthcare teams, working with consumers to really reduce. And they saw actually a significant reduction not only in dose, which is important, but in use overall. But we need to engage both those caregivers and the patient and the care team. So they have some really awesome tools online to do that. So the take-home points, because I have to wrap up, is medication use and safety in older adults continues to be a concern, especially in those that are older with multiple comorbidities and cognitive disorders. It truly takes a team. I think our evidence, as well as coupled with others, show to address medication management. But what we need to be very cognizant of is our patients are navigating this very fragmented healthcare system and seeing multiple providers who may be prescribing high-risk medications, and communication and coordination is really critical. And I really am pushing health systems to look at this construct of deprescribing and how we support it, whether it's a clinical initiative or a clinical program to improve med safety. So with that, I'm going to leave the podium to our next speaker, and I stayed on time.
For our third and final speaker, I am pleased to introduce Dr. Ann Gruber-Baldini. She is professor in the School of Medicine, Department of Epidemiology and Public Health. Her clinical research expertise includes areas of measurement, study design, data collection, and conducting and interpreting analyses, and in writing manuscripts. She's been conducting research on psychosocial factors in aging and chronic disease, and she leads the Division of Gerontology Statistical and Data Management Group, which has provided data management statistical oversight to a number of large longitudinal studies, including the Maryland Long-Term Care Projects, the Baltimore HIP Studies, the Mobile Health and Diabetes Projects, and the University of Maryland Movement Disorders Quality of Life and Function Study. She's here today to speak about cognitive impairment after a hip fracture, measurement, and impact on recovery.
Thank you. Yeah, that's good. Thank you. And again, it's funny thinking about clinical research. I'm not a clinician, but again, I've had a lot of experience with some data and some participants in our research studies over the years that I think have some implications for the clinicians and groups in this audience. I want to thank some of the funding agencies and groups around here, funds from the NIH, including grants to Jay Magaziner from the NIA, the Pepper Center, and I also had a funding from the NHLBI that I'll be giving some findings from. A lot of this work is coming from the Baltimore Hip Studies group, led by Jay Magaziner, Denise Orwick, and Mark Hochberg. And I want to actually thank the people who did a lot of the work, Eric Barr and Mina Husseini, with helping with the analyses. You're here, hopefully you realize that there is the Baltimore Hip Studies that's been here for 20 or 30 years, but for those of you who may not know about hip fractures, it's estimated that currently there are about 1.6 million fractures per year in the world, and in the United States it's about 250,000 hip fractures for those 65 and older. This number is actually down a little, and so we do have some feeling that maybe some of the rates are going down. But as Dr. Blumenthal was talking about, the sheer numbers of people who are going to be getting into these older age groups, the baby boomers and stuff, is going to drive up these numbers such that by 2050 we expect about 700,000 hip fractures in the U.S. and 3.9 million worldwide. And hip fracture is not good. It increases the risk of death, disability, increased cost, a lot of bad outcomes. This is sort of a risk factor model for hip fracture, and it's sort of cliche, I sort of say it's bad luck and bad bones, right? So if you have bad bones, bad architecture, low bone mobility, it doesn't take much of a fall to break the hip. But if you have a bad enough fall, you can break your hip. And so one of the things that's important to keep in mind is when we're talking about dementia and cognitive issues, those with cognitive impairment fall more. They may even fall differently, we're not really sure about that, but just falling more and more increases your likelihood of breaking something. So, oops, I'm going backwards. J. Magaziner has shown from a number of studies that, first of all, if you look at the top line, recovery in lower extremity activities of daily living often takes up to 12 months after the fracture. That's where the recovery is peaking. Most of these people do not get back to where they were before the fracture, but they are still recovering up to 12 months later. I've highlighted in yellow the cognition. Again, the trajectory for recovery from cognition after hip fracture may take up to 4 months. So again, think about our normal care. We're out of the hospital in 3 days. We're out of the rehab in maybe, if you're lucky, 2 months, if it's long term, usually within 3 or 4 weeks. So these people are still trying to recover, and what are we doing to really sort of optimize that? I will tell you there are a lot of people with cognitive problems and hip fractures, and I'll show you all that data that you need to know. But why do we think this is happening? Is it sort of unrecognized dementia? There's a lot of dementia we know about. There's a lot we may not know about. And then this whole issue of delirium, which I'm going to go into a little bit. And again, I think we see it in hip fracture, but again, other clinical care settings, you see a patient come to you and you don't know why they're not cognitively normal. And you're trying to figure out exactly, is this existing? Is this new? What is it? Certainly, dementia is a risk factor for hip fracture because it's a risk factor for falls. Hip fracture causes awful things that's going to affect your brain. It's physical stress, surgery, pain, and pain meds. So we've talked about medications, but untreated pain can also make you delirium. Anesthesia, blood loss, all of these are very big risk factors for delirium. And the average age of hip fracture is around 81, 82, and the single most well-documented risk factor for delirium and dementia is age, as Dr. Blumenthal talked about. So I did want to bring in the idea of delirium. I know Dr. Brandt talked about it, but delirium is an acute change in condition. And the confusion assessment method by Sharon Inouye is one of the most popular ways to sort of diagnose this or in the research world. And it sort of does operationalize a lot of the, at least the DSM-3 and DSM-4 criteria, with the idea that you have an acute change in mental status with a fluctuating course and inattention, and you either have disorganized thinking and or an altered level of consciousness. I do believe DSM-5 plays with the definition of consciousness, but I still think it's applicable. Delirium versus dementia. I mean, delirium is acute onset. As Dr. Blumenthal said, I mean, there are other things, but most Alzheimer's especially do you see memory disturbance. In delirium, you really see problems with attention. They really just can't focus in on what you're telling them. You may have some altered consciousness that you do not see in dementia. It's fluctuating over the course of minutes and hours. Certainly, people with dementia can fluctuate, but it's not minute to minute. And the real reason we were interested in delirium is potentially reversible. Dementia, as we've seen, is not reversible at this time. It's barely treatable, to be honest. So again, it's something we want to pay attention to. In addition, we get this lovely thing where you get delirium superimposed on dementia. What the heck am I talking about that? You can have this inattention, this fluctuating course, even amongst people with dementia. And again, it's very unrecognized. And it's people with dementia are more likely when they're in a hospital setting to have delirium. It's very hard to differentiate, and it's very unrecognized, but people with dementia and delirium do worse. And it seems to also be related to longer delirium exposure and actually may lead to a stepwise decline over time in functioning among those with dementia. So delirium is really important, and to be honest, it's fatal. If you don't really treat the underlying cause, your likelihood of mortality is much greater, and so it's something we really need to be paying attention to. So I'm going to take you through sort of like a personal history of my research in terms of trying to look at various data. Collecting data is my thing, and looking at data sets, and how have I sort of tried to deal with these issues of cognition and dementia and delirium. So the first data set I'm going to work is called, we call it HIP, we number, the Baltimore HIP Studies 2, HIP2, which was collected in the early 1990s, where we really tried to look at delirium and dementia, the pattern over time, and consequences. There were 804 people. We had community dwelling. We always focus on community dwelling for hip fracture patients over 65 and older, and 674 in most of the analyses. Some of them are limited to people with follow-up. And we did follow up people in this data set to 2 years. So that lovely slide set where I talked about pattern of recovery, that came from this data set. And it's recruited in early 1990, 91 from 8 Baltimore hospitals. Again, as I was already saying, the mean age is about 81. So again, these are not your young old, these are more of your older old folks. As we see pretty consistently, at least in the United States, it's primarily females and primarily Caucasian white Americans. The idea being that there are a lot of comorbidities. If you exclude dementia, which I'm going to tell you is very common, on average, people have 1.5, but only 27% had nothing else. And we had 23% who had 3 or more. So think about 3 or more comorbidities, probably 3 or 4 or 5 more meds. All these things are all coming together. I'll try to go over this. I came in on this, and so they actually had a whole bunch of different measures. So they actually had chart notations of dementia, Alzheimer's. I think they even had organic brain syndrome back in the 1990s. Hopefully you're not finding that in your charts anymore. But the one thing that this study did, which was very nice, is they actually interviewed the significant other family members about history. And you'll see that that's really important because a lot of people don't get their Alzheimer's and dementia pre-existing diagnosis in their charts. We also had them sort of rate how were they cognitively, using sort of we used a mini mental. It's very unusual to do this, but there are other measures where we sort of ask them about what they were like. And again, there's a lot of people with undiagnosed dementia out there, so we're trying to sort of untangle that and see what we're seeing there. And in the hospital, again, we had the notations in the chart, and as you'll see go through that, delirium is very underdocumented and underrecognized in hospital settings. So you have to look for it. And again, unusually we had the significant other rate delirium at admission, and we also gave the mini mental in the hospital. And again, these are back when the hospital lengths of stay were more like 10 to 15 days. So almost all of our folks were still in the hospital 3 to 5 days later. Again, the mini mental status exam is used for dementia and delirium. It's not specific. It's giving you an overall status. It's not telling you where they came from. It's just telling you that they're having problems. So again, I didn't always have the perfect measures, so what I had to sort of do in my mind was sort of who had it beforehand and who got something new when they were in the hospital. And so based on the history and the significant other history, I estimate about 28% had something that might be dementia beforehand, right? I had about 30% when I tested them, they did poor surgery, but only 8% of the sample had it now before surgery that they didn't have it before. Then I had 48%, if you give a mini mental 3 days later, you're going to get like almost 50% are going to fail it, right? But again, it's 14% who didn't have pre-existing, didn't have delirium at admission. And then I had basically half of my sample seemed pretty good. And what's interesting is the pattern of persistence over time. And so the blue bars are to 2 months and the orange bars are all the way up to 12 months. So those who seem to have no cognitive impairment, about 10% of them got less than 24 in the mini mental later down the line. And that's pretty there. Those who were impaired, about 75 to 80%, you'll still have people with dementia who can pass a mini mental occasionally. But what's interesting is that the persistence for either the pre-surgery or the post-surgery impaired was at about 40 to 50%. So again, a lot of these people were still having symptoms of delirium or whatever it was 2 months, 12 months later. At that point, it's moved on beyond delirium, so something's going on. I didn't show this, but I'm sorry. But again, the idea being that we had a gradation, that obviously those who had no cognitive impairment did the best. Those who had it before their surgery, after the fracture, did the worst. And these two groups in between were in between. So we did see that these groupings were prognostic in terms of their recovery. I just also wanted to make a point that, there is still recovery even amongst people with dementia and even with severe dementia. And I just wanted to do this. So this is probably the most grossest idea of thinking of it, because they even walk 10 feet. This is with assistance, whatever. And so certainly if that testing in the hospital setting showed them they were less than a 10 or less on a mini-mental, very impaired, at 2 to 12 months, about 30 to 40% could not walk. Flip side, 60 to 70% could walk. So again, the idea that we shouldn't rehab or intervene with somebody with severe dementia is not necessarily warranted. And again, we do see gradations such that those who are more cognitively impaired are less likely to be able to walk. But again, still the vast majority of subjects are at least able to walk across the room. And that has a very meaningful impact on people's quality of life, being able to get out of bed and at least get across the room. So again, I come out, this is the first study I'm doing in hip fracture and cognition, and I see that, there's a lot of cognitive impairment amongst such people with hip fracture, right? And those who get it in the hospital and we don't know they had it beforehand seem to keep it. And what's going on here? And again, they had the worst impairment, recovery. But again, these measures weren't always consistent of time. The delirium measures were really not standard. I mean, now there are people who are starting to involve significant others in helping them determine delirium. But really, the standard is really to go out and assess it with some sort of clinician while you're in there. And we didn't have the same measures pre-surgery, post. We had all these kind of messed up kind of things. The pre-fracture measure of the SO rating of mini-mental is unusual. I think we're the only ones that ever used it. But at least it gave us something, right? And we can't look at delirium superimposed on dementia, given the way I've measured it. I can only just sort of group them by when did it first show up kind of things. So that led to the FOCUS, which is a Focused Cognitive Answer study, which was funded by the NHLBI. This was an add-on study to an existing randomized clinical trial. The good thing is I think I got like my best measurement I could get out of this. So I was really happy. I got to design this. And I worked with Ed Marcantonio up at Harvard and to really work on this measure. So at the time, we had a structured delirium assessment that took about 20 minutes. I will tell you that, it's actually on my earlier slide, that he and his group with Sharon Inouye have developed a 3-minute version of that. Much better to do than a 20-minute version, I'll tell you that. But it did involve the mini-mental, but what happened is we sort of focused in on some of the attention items. Moving on it, sorry. Sorry, I've lost my thing. The attention items, we added a couple more attention measures. We also looked at other symptoms of dementia and delirium, and we had some ratings, and we did have the confusion assessment method. What we did is we had it 5 times, so we had it before randomization, which was usually around surgery, as 3 times in there until they were discharged. And then we followed them up at 30 days. So it was either in person or phone we did an assessment. I did have my significant other history, and I had a better measure of sort of decline, what we call the IQ code, the informant questionnaire, which has been validated to be predictive or at least indicative of dementia, which is we asked them about what they were like before the fracture compared to 10 years ago. This is the whole how we got them, blah, 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 blah. The big thing is there were 139 subjects in my study. And I'll just tell you, they were randomized transfusion group. There was no effective transfusion on delirium or most of the outcomes. So I'm just going to lump everything for simplicity's sake. Again, age 81, 82, female, white race, majority. Here I got 32% of people had dementia. And if I'd relied only on the chart, it would have been half. So again, asking the family members about their history and what they were like really uncovered a lot of potentially non-diagnosed dementia. Again, if I went by, when I did a delirium, 44% had delirium in the hospital. And only 19% was recorded overall was recorded in the chart. Again, I've more than doubled my delirium. It's a little complicated, but again, 40% of the sample had neither dementia nor delirium, 12% dementia only, 24% delirium only, and 20% of the overall sample had dementia delirium. And again, the persistence of these delirium symptoms sort of, again, varied by that, such that 6% of people who didn't have it in the hospital seemed to have some problems at about 45 days. 17% of dementia had delirium, 14% of delirium persisted. But of those with both, 30% were still meeting criteria for delirium 45 days later. If we look at sort of the functional outcomes, Focus only had a couple questionnaires, and this is their main outcome, was the ability to walk independently without assistance at 30 days, and those who died, who had other data, are concluded as not able to walk. And so dementia and delirium were both independent risk factors and doubled the odds of your not being able to walk independently at 45 days after a hip fracture. And you can see transfusion today. If I go in and actually add the 45-day delirium measure to look at 60 days, that persistence to 60 days, the 45-day delirium was a very strong marker. Dementia and the 45-day delirium these are almost 4 to 5 times greater odds to the ability to walk independently, even controlling for delirium in the hospital. So again, delirium that persists is really important to pay attention to. So that's what I was saying there. And again, we were able to sort of see that maybe following these people up to see how they do may be important to figure out if they're recovering or not, or if there's something we may want to do more of. All right, I'm done in 6 minutes. But again, I had 139 people. I only had that functional question, and it was only to 60 days. So I'm going to go back, and I'm going to go in now to the 7th Baltimore hip studies. And here I'm going to just talk about, this actually oversampled men and women, so we actually have equal samples of men because we believe, because men are also getting older, we're having more men who are fracturing their hip. Even though they're less likely, we believe the sheer numbers, again, are going to increase the number of men who are fracturing their hip. So the main study was to look at that. Here, again, I didn't have any good hospital measures. I only had their history. And so, again, I've sort of gone back on those measures. The one thing I did have is more longer-term follow-up on cognition. And so for this, I used a modified mini-mental, but I can get a mini-mental equivalent. I also did get a Hooper and a Trails, and they follow some similar patterns, but I'm not going to focus on them. I didn't want to get too distracted by all the different measures. And I look at mortality. I have actually physical performance measures, the SPPB, which is measured by chair rise, gait speed, and tandem stand balance. Again, similar ages, race. The only thing we found differently between the men and women, at least demographically, was that men were more likely to have a spouse. Right? They're 53% of them have a spouse living because their wives are surviving, whereas only 29% of the women. And the men are sicker. And that's, again, you'll see why this becomes important. We know that the men who fracture their hip do worse. There's a little bit more dementia, but again, you can see these rates are in the 10 to 17%, not like what I was seeing when I asked a family member. And the delirium, it was like 9 to 10%. So again, I'm missing a whole lot of delirium in the hospital if I rely on the chart. If I look at the cognition scales over time, what we found that we're overall level differences. So the women do better, the men do worse, and there were no differences in trajectory. Although I can't quite explain why the men sort of get worse and then get better. It's not significant, but it's not only but I see it in the survivors. I looked at the dead people, I tried everything. So there's a couple men who really seem to have a lot of adverse events or something that's affecting their cognition there. For those of you used to mini-mental equivalents, you can see the average scores actually I should go back. If you think about the cognitively impaired, 22% of the overall sample would be the cutoff. And again, you can sort of see those of you like that 23, 24 cut point in the mini-mental, you can sort of see the same pattern on that. Let's get to our outcomes. So in terms of the big one, mortality, right? We're really interested in that. We found that both gender, sex, and cognition were very strongly predictive of 6-month mortality, such that if you were a woman and you were cognitively intact, 98% of you were alive 6 months later. If you were a man and cognitively intact, it was about 89%. If you were female and cognitively impaired, 85%. And those poor cognitively impaired men, 25% of them died within 6 months. So this is really, really strongly telling us that something is being marked, at least by our cognitive measures, that sort of is very predictive of our mortality. Again, I didn't get rid of the gender difference, but I at least can give you that. I got rid of the gender differences. I'm running into power issues, at some point, but I just wanted to show you a little bit about cognitive performance for these performance measures. I'm getting close on this. What we found is a very clear level difference that the more cognitively impaired you were, the worse you did on your SPPB score. So you just sort of, right down the line, the worse you get, the lower your scores on the SPPB. These are pretty low scores. I think you were showing our hip fractures are very, very cognitively impaired. I've been physically impaired. Let me break that down for you, because I know I have the Pepper people, they know what gait speed is. Again, we actually do see a trend difference and a level difference by cognition over time in gait speed. Again, averages are all below 0.6 meters per second, really slow. You can't get across the street without getting hit by a car at 0.6 meters per second. And what we can see is that for almost every group except that very bottom line, which is 3MS less than 65, probably like a 16 or 15 or so on the mini mental. Everybody gets better. Some get better late, some get better early, but they're all getting better. But the people in that lowest group do not get better. This is a little bit more striking. 5 chair rises without arms. Everybody's getting better except that bottom group, nobody. It's only 10 or 15 people. None of them can do it up to even 12 months later. Very striking. That's, again, thinking about the region that's really impaired. So, see, I'm getting here. Again, we see that men are having very bad cognitive functioning. The recovery doesn't differ by sex, but only level. And this 3MS is the most prognostic out of all of the measures for mortality and functioning. But most showed some recovery. Again, I don't have the best measures, and I know there's other things going on that I'm not measuring. Just sort of the overview and the summary. Again, dementia, the first 2 studies, I'm getting about 28 to 32%. This last study, I did not have a family member giving me information, so I'm missing over half of the cases of dementia. Delirium, same thing. It's only that focus study in the middle where I have a really good delirium measure. I get 44%, and the other studies, I'm only at 18 to 19%. If you think about cognitive impairment, this is from the mini mentals or the 3MSs I get when I get after the surgery. You measure, you get at least 21 or 22%. And again, the first 2 studies at least had chart and family members and some other stuff. And only in focus can I look at the combination. And there you can see that among those with dementia, delirium is prevalent in about 46%. So again, how you measure really makes a difference on who you detect and how prevalent these conditions are. The other thing is, I don't know if you were noticing with those lines, but a lot of these people weren't really stabilizing in their cognition or even their functioning in that first 6 months. And so when we think about when we do rehab and when we do things and it's related, are we really timing these things correctly? Because they're still getting better in their cognition and we're trying to get them physically. They may have other potential later down the line. Do we have to think about different kinds of sequences? Do we have to think about maybe extending or changing the timing of rehab care? And again, this is standard care. It's not necessarily optimal care, to be honest, to be frank. So we don't necessarily know there may be better approaches and things of that sort. And certainly as researchers, I really want to understand a little bit more why they're doing so bad, and is there more potential going on here? Are there ways to prevent or treat this a little bit? Again, most of our work, at least in delirium, suggests it's better to prevent than to treat. Our evidence is better there. And again, people with cognitive impairment are often excluded from a lot of these clinical trials, clinical interventions, and it's the most unrecognized group with the poorest outcomes in its clinical practice. Just a little plug for my current study. I have an R21 through aging that I'm collaborating with Beth Galick and Barbara Resnick over in School of Nursing, using a function-focused care intervention for caregivers after their usual care, with the idea being that the caregiver interventions, I think were the ones that looked best on yours, Dr. Blue. I think so. Was the idea thinking this might be a nice optimal time. They're not doing so well. They're coming. Some people are coming home, and their caregivers are going to get overwhelmed, and they're afraid they're going to fall. So they're like, "Mom, just sit there. I'll bring things to you." And a lot of our behavioral symptom interventions are, let's keep them calm. But I think the issue is with fractures, we want them to keep moving. We want them to get better. We don't want them to decondition. We want to keep them going. So this is something we're doing to try to work individually with the in-home setting in this care transition. I have no subjects, so if you have anybody, please send them to me. And with this a personal look, this is my grandmother, Helen Gruber, and her daughter, Helen Ann Dugan. And my grandmother died of hip fracture. And my aunt suffered a hip fracture in November and has not yet gone home. So I want us to solve this problem now, but that's another study. So that's it. Thank you. And I think I went over. I'm sorry. I went over.
I'd like to thank our three speakers, Dr. Gruber-Baldini, Dr. Brandt, and Dr. Blumenthal for speaking today. How do you guys want to do questions? Do you want to do panel or just have yourself available for individual questions? Ask them. Yeah, to be respectful of time, why don't we just have, our three speakers will be available for a few minutes to answer questions, and you guys can help yourself. Also, just some refreshments outside. And thank you for attending today, and we hope you'll join us for our next one, which is scheduled for April 26th. So be on the lookout. We will be publicizing that shortly. Thank you.